to see my presentation now?
Yes.
Okay. Can I start? Just let me know.
Yes, you can start.
Okay, thank you very much. Okay, so my name is Fadwa Abu Mostafa. I'm talking to you today from Saudi Arabia, Medina city specifically. And the research that I'll be presenting is titled with Assessing Knowledge and Compliance of Patient Identification Methods in a Specialized Hospital in Saudi Arabia. So basically, we are a tertiary health care organization. The research was done in our branch in Riyadh. It's the main branch. However, currently I'm working in another branch who opened recently 2 years ago in Medina. Our branch in Riyadh is kind of a big hospital, almost 1,600 beds, and you can imagine, you know, how much also different nationalities are working in this hospital, almost 56 nationalities on board. So when we done the studies at that time, I was the assistant director of quality management department, and having or working with different specialties and also looking into what type of incidences we are having reported in our patient safety system, we realized that there is an issue related to patient identification, which is really a basic thing. Maybe most of the healthcare providers already understand the importance of it. However, it was a kind of an issue, and there was severe incidences being reported related to this topic. Just a bit of an idea about our center here. It's Academic Medical Center, the one that we did the study in. And it does focus in those areas, medical genetics, organ transplant. Oncology is one of the important services that we are offering also in the hospital. Neurosciences and cardiovascular are also important services, and we are well known to be specialized in those services and provide also excellence in them. My name is Fadwa. I'm the one at the top, but I had with me also a couple of assistants in doing this research study. Dr. Amal, she was representing medical and also at the same time research center. I had with me also someone who was working in quality management as a quality coordinator, Mr. Hadi, but he was also with a background of nursing. And I had also Ms. Hanan, who had the background of data management, and she helped us a lot in the statistical analysis of our study results. So just to give a background about the issue and its link or connection to oncology or cancer patients. As I mentioned, oncology was one of the services that we had really a great hands on it in our hospital. It's important services, and we do have provide the chemotherapy. We do provide also the radiation therapy to our patients. And it is very important to ensure that when we are providing these very critical services to those patients, to ensure that it is done in a safe manner. And one of the safety measures that we need to apply all the time when we are dealing with such patients is to identify them properly for the procedure or the operation or the surgery that will be done for them, or the chemotherapy that will be provided, or the radiation that will be they will be exposed to. So considering this thing, we found out that it was important for us to be looking into the areas that provide all of these services and consider some sorts of what is the root of these issues, why it's happening, and whether it is happening. Is it, and the first question came to our mind, was it deficiency of knowledge or it's a problem of compliance? Because we had a couple of misidentified patients in our services whom they end up with either minor harm or severe harm. Some of the minor harms that we had is maybe getting overdose of certain medication that did not impact the patient too much, and we were able to handle. But in fact, there was some incidences of switching between patients, so wrong patient took the chemotherapy of another patient just because of the similarity of naming. One of the issues that we also observed in our organization, that due to the similarity of the names of the patients, many patients that we can get in our organization, they can have the first, second, third name are all similar. And the only way to identify them is by the medical record number, which will be unique for each patient. However, healthcare providers sometimes did not pay attention to confirming or looking into those medical record numbers, which did compromise the identification, the accurate identification of the patient. Now, this was not only an issue in our organization. When we looked also into the literature, we found out that Joint Commission also in US and also Joint Commission International, both of them, they reported the misidentification of patients as one of the main reasons for having sentinel incidents. Sentinel incidents mean a major incident or serious incident that results into death of a patient or loss of function, and mostly here we are talking about permanent loss of function. So looking into this in depth again, we thought let's focus in our hospital in different procedural areas and outpatient areas. So our study aim was to look into two components, and they are the main components for people maybe not performing what's expected from them, and one of it is a knowledge deficiency, and the other part is compliance with the hospital policies, regulations, and guidelines. So the study itself, we had two levels of doing the study. The first level was doing a survey with the questionnaires to assess the knowledge of healthcare providers. As you know, patient identification policy in our hospital require that the patient will be identified by two identifiers, the patient medical record number and the patient name. However, for oncology patients, especially those who are getting radiation, our radiation center added, but put it as a preferable thing to their patients, which is identifying them by pictures. So they were taking pictures from the patients who are under treatment in the hospital and keeping that picture also in the files. But it was not mandated all the time or in all areas. They kept it optional as per agreement of the patient. And the second part is observation audits. So what we did, we looked into all procedural areas, and procedural areas included the areas of providing chemotherapy, the areas of providing ultrasound, MRI, any radiological procedures, the areas of endoscopy and so on. So all of those considered procedural areas, and in those areas, it is mandatory that the patient will have ID band, and at the same time, it is mandatory that the patient will be identified using the two identifiers. Now, the people who did the observational audit did not inform the area that they are doing that, because we wanted it to be like secret shoppers, where people there won't be trying to do the right thing or the appropriate thing, you know. So we just went there. I did the audits, part of the audits myself. So I used to go there to the clinical areas where they will be calling patients, and I'll pretend that I'm doing any type of audits, like documentation audits or anything else. But people want to know that I'm just observing what they are doing when they are identifying their patients. Sorry. So this is the population that we have considered in our survey, and also for the units that we covered in our study. So basically, total of 402 healthcare providers, 402 participated in our study. So we had really the number that we wanted. Also, we got non-healthcare providers. Why we did that? Because not all people who are really dealing with the patients are healthcare providers. Sometimes also others, like food services and others, they deal with the patients, and also they need to confirm the medical record number and the patient ID. So so this was the survey part, and the other part was related to the doing the audit itself. So in relation to the audit, these are the units that we covered, and as mentioned, they were all outpatient: radiology, radiation, oncology, hemodialysis, day surgery unit, in vitro fertility, IVF, endoscopy, laboratory, dental clinic, pre-anesthesia clinic. And as you can see, all of these areas, it is very critical for the patient to be identified appropriately and properly for the future administration of medication or radiation, or even to do procedures or operations on them. This is the survey questionnaire. It's not included, in fact, it's not posted with the research. People can get it upon reaching to me and or other co-investigators, and these are specifically the questions. Part of it was the first part was about demographics, trying to identify the healthcare providers, and or if they are from clinical areas, and the other part from non-clinical areas. There is sorry, couple of questions which is like around 13 questions, and they handle different knowledge aspects related to the patient identification. Now, of course, after we collected all the feedback from different healthcare providers, we analyzed, our questionnaire response and looked into the areas that was answered appropriately versus those whom we did not get good answer for them. Then after that, we did observational audits. Now, in the observational audits, again, as what I mentioned, we used to go into the units, and these are the items that I would check them with every patient, and for each patient transaction with different healthcare providers. The focus here for this auditing is to audit different healthcare providers, not only different patients. And you could see really that each healthcare provider would have a button, okay? So those who are just identifying the patient with the name only, they will continue to do that with all patients. They are not changing their behavior from patient to another. It's something that they set and go with. So we tried to target more than one healthcare provider to see the pattern and the behavior of identifying patients. These are the items that will be audited. What is the date? Of course, I just specify the date of doing my audit and the exact location and the chematic number, which is like a number that identify the patient. And I tried here to select chematic numbers randomly, just to be, avoiding bias. And then who performed the identification, which nurse, in order to be sure that I do, capture more than one nurse or more than one nurse assistant in the area to see how's their performance in relation to the items audited. And then I will look at if the patient name and medical record number being checked. And to my surprise, most of the time the patient name will be called, but not the medical record number, and unfortunately also not the full name of the patient. They were calling the patient only by the first name. Hardly you can find someone calling the patients with two names, the first and second. And the other item is, has the patient or guardian been asked to verbalize the patient name and ID number? So also we had a difficulty in getting people doing this exercise, because basically the nurses, they were calling the patient. For example, they will call Fatima, and of course this Fatima will show up. They will just tell her name. Okay, are you or ask her, are you Fatima? And she will say yes. Then they will start to do the remaining procedures. I have witnessed that myself in the IVF clinic, which is one of the high risk clinic, and we had incident really happened in that clinic that was really serious, due to the nature of what they are doing in that clinic as a procedure. So really there was a very poor documentation, very poor identification of the patients in those clinics. Has the healthcare providers utilized two identifiers to identify the patients? So this so the answer here will be no, they used one identifier, two or none, and so on. Then we put our comments, what was the missing parts, in this transaction, and so on. So when we did this exercise, again, I mentioned some of the areas that was deficient, and it was eye-opening for us, because this is not only estimated, it was the real situation on the ground. This is just my instructions that I put for the auditing, because I did the audits with other people also. We were like 3 of us who were doing the audits, and each one needed to do the audit the same way like the other one. So to have a standardization among us, this was the instructions that we followed. Now, outcome of what we got is there was a high level of knowledge about the policies of the hospital. Yani I cannot recall that in any of the answers, anyone did not know that we have to use the two identifiers, the patient medical record number and the name, because there was a lot of campaigns and a lot of education and focus on this policy specifically to all healthcare providers and non-clinical staff. However, so it was not the knowledge here. Almost 90% of the responses were up to our expectation, or they were positive. However, the problem was severe when it comes to the practice. So there was a gap between what people knew and what they were practicing. Shortcut was one of the main practice issues that we have seen in different areas. People even became more creative and innovative in the way how to do these shortcuts. And one of the areas we found them even using the chematic tube, the chematic numbers, which is a ticket issued when they come to the clinics in order to sign in, that they are there. They were utilizing it in order to write the name of the patients on the back of them, and that's it. This will be the only identification for the patient. So shortcuts were common and were utilized by healthcare providers, and use of patient name was another thing instead of both identifiers. So in less than 20%, we found two identifiers being utilized in the clinics. Also, there was a very low use of verbalizing or asking the patient to verbalize their names, which is also important because a lot of times when you are just saying the patient name, sometimes the patients have been sitting for a long period of time and they just want to reach to the physician or to the service without realizing that it can be risky if they are the wrong patients. And we have this when we investigated as a quality management department staff, one of the incidences which was related to wrong patient taking the chemotherapy in the outpatient, we found out that the patient who responded to asking her for responded in order to get the therapy was the wrong patient and with the wrong name, but she said that she was bored and she wanted just to get in and take the service. So this, I'm thinking, trusting that the healthcare providers will be checking and so on, which did not happen in that case. Properly end up with a patient taking a medication of another patient. So we realized that resolving such issues is not something that can be done only by education that we are used to. As well known, Yani, it is education is not of it is not an action that would help in complete resolution of such issues, and that we need to dig down more to look into better strategies that will prevent our staff from misidentifying the patients and so on. Several actions, in fact, done by quality management department, besides, again, as what I said, the awareness and the other things, mandating having ID bands for all patients in the procedural areas, and mandating that all healthcare providers are doing the full identification for the patient prior to receiving any services, more supervision in different areas, more auditing and reporting, carrying more accountability, if incidents like that happened on the healthcare provider, it became one of the issues that if it's been identified in any department, it will be a big fuss. They will really take a brief and discuss it in depth and do root cause analysis for it, because it became a red rule and no one would be accepting it at all in different areas because of the consequences that can happen from it. Now, also, we discovered that we had a lot of focus on outpatient areas, but we didn't want to forget the inpatient areas because nothing been happened for them. So we started as a quality management to look into these areas. The issue in the inpatient was less serious than in the outpatient. Because most of the patients anyway, upon admission, they will be handed over their ID bands and so on. However, here in Medina, as a new site, I noticed that the nurses were sometimes not putting the ID band in the patient hands, and the patient would refuse to do that, to wear their ID band. So they were hanging those ID bands in on the bed or on the bumps and so on. So we stopped this practice immediately, and we insisted that each patient should really have an ID band all the time. Again, I think overall it was a great to know all of these gaps in our hospital, especially for oncology patients. And it did help a lot really in us focusing in those areas and trying to eliminate or reduce any further serious incidences that could happen, due to misidentification of our patients. With this, I'll conclude my presentation, and it's open for you if you have any questions.
Many thanks, Dr. Fadwa.
Sorry?
So many thanks for your presentation.
Yeah, my pleasure, my pleasure, my dear. I hope you enjoyed it, and also the attendees.
Yes. Now, if anyone has a question, you can ask Dr. Fadwa about what she says. No questions.
Okay, so have a good day. Thank you.
Everything was clear. Thank you.